Hey everyone, this video is on indications for acute dialysis. And I suspect right now you're wondering why, right? Why would a surgery resident make a video about acute dialysis? And I will be the first to admit that I am no kidney expert, right? I'm not a nephrologist, and this is not going to be a comprehensive talk on everything and anything you could need to know about the kidney. But I actually make these videos primarily for the students that rotate with me on surgery. And I think it surprises many of them when they come on our rotation, but there is a lot of medicine involved in surgery, and especially general surgery. Actually, in our residency, we do at least as much, if not more, inpatient medicine than many other residencies, including internal medicine, because we don't do outpatient. So anytime we're on a service, we have a bunch of inpatients that we're monitoring. And we certainly don't see the breadth or the complexity of the medical disease that our medical colleagues do. But it is something we deal with all the time, and it's important for us to know both what we can do and how to diagnose these things, and then exactly when it's time to hand it off to the experts. And this is one of those times where if somebody needs acute dialysis, that's when it's definitely time for you to talk to the nephrologist and get them the care they need. But up until that point, you need to be monitoring those changes, trying to do some initial treatment. I just find that spelling out these indications is a really helpful and important part of surgical medicine. And the other aspect when it comes to medical students is that we're really trying to take a big picture approach here. Sometimes I think when you learn from specialists, it can be hard to see the forest for the trees because they're telling you every little detail. Since I don't know every little detail, I can't tell them to you, and we'll keep this a really big picture, kind of practical focus as well. Because even if medical students can rattle off kind of these 5 classic indications, frequently I'll say, okay, but how would you evaluate that in the hospital? And then there's a little bit of struggling. And so what we're trying to do here is take that really, practice, step one ready theoretical knowledge, and then start translating that into how we think about practical medical data. So anytime I'm asking a medical student about indications for dialysis, I'm always talking about that AEIOU mnemonic or acronym. And so if you can remember that, you're well on your way. And so we're going to go through each of these indications, and we'll talk about the subjective and objective, primarily objective methods to rapidly assess and kind of make decisions about many of these issues. And I think we get pretty good at this actually as surgery residents because we have to make these decisions, either at 4 a.m. pre-rounding or frequently when in the OR, hearing about a patient from a distance. So we have to get really good at thinking about what objective data we can get if we're, for example, scrubbed in, or what data we can get pre-rounding before we run around and see all the patients at 4 a.m. Before we go in the OR all day and start to think about making these decisions. So hopefully that perspective will be helpful to some of you. All right, so the first letter here is, of course, A, and that stands for acidosis. So really we're just talking about hydrogen ions. And when we think about the objective assessment of acidosis, this is all about lab values. So first you can think about your basic metabolic panel, and we're talking there, of course, about your bicarb. You can also get a VBG or an ABG. If you're really concerned, you want to get that specific pH measurement. That will also give you some additional data in terms of base excess. Of course, a negative base excess meaning acidosis. And of course, you'll also get a measure of your CO2, which can make you think about how severe the respiratory compensation is, because that can often be one of the more severe issues with these patients is if their metabolic acidosis continues to build up. They've got dropping bicarb, decreasing pH, and they're working really hard, breathing down their CO2 quite significantly, and they're starting to struggle either to keep that fast pace up or they're using accessory muscles. Concerns about respiratory decompensations could be a major driver of the need for dialysis in some of these patients. Moving on to E, we're talking about electrolytes. Of course, not all electrolytes are created equal. Many of them we will ignore, even at quite high levels, but the big one to think about with dialysis is potassium. And then, of course, objective data for potassium is quite straightforward. You're just getting labs and looking at potassium in them, either as in isolation or as part of your basic metabolic panel. But another piece of data that's important to think about if you have a significantly elevated potassium is to worry about the heart. And so we're usually getting an EKG to further work that up. And what you're looking for there initially is something like peak T waves. Let's draw peak. That's some sort of peak right there. And then that's going to progress to a widening of your QRS. And then ultimately, worst case scenario is arrest, which usually looks like a sine wave. So frequently, somebody comes out of the OR, you get a set of post-op labs, and there's some fluid shifts that happen in the operating room. All of a sudden, you have a really significantly elevated potassium. And then you're thinking, okay, do I need to do something about this? Usually, good first step, get the EKG, look for those changes. If you see those changes, then the keys to thinking about managing acute potassium elevation is, of course, stabilize, which involves giving calcium to stabilize the myocardium, help prevent those arrhythmias. Shifting, which is about moving the potassium out of the bloodstream, but not necessarily out of the body. So that's things like insulin and dextrose, potentially albuterol or bicarbonate. And then you can actually remove potassium from the body with either diuretics, so through the urine, or through the stool with drugs like Kxalate. And all those things are kind of those temporizing measures that you can do to see if you can get the patient on the right track. But if you can't, or K continues to climb, of course, that's when we would be thinking about calling nephrology and worrying about dialysis. This is actually, from my perspective, the least important letter. I'm very rarely, as a surgery resident, working somebody up for undifferentiated acidosis, in which ingestion could play a major role. So we are actually not going to talk about this one. Oh, this is a big one. So this is volume overload or fluid overload. And we can actually get a whole lot of objective data when we're thinking about fluid overload. One thing that many medicine services don't have the luxury of having are medicine floors in the hospital, but a lot of our services will be watching patients' daily weights. So if their weights are going up, that's a pretty significant sign, pretty obvious sign as well if you're paying attention to it. Some of our patients are getting daily chest x-rays. So in that case, you're looking for things like pulmonary edema, which of course is going to go along with things like an increase in oxygen requirement, maybe some increasing respiratory support. And usually all this is in the setting of a low or absent urine output. So they're taking in fluids for whatever reason, maybe orally, maybe IV fluids, and then suddenly, or maybe gradually over time, they're just not able to get rid of them. We're seeing their weight go up, and really what's going to be pushing us to deal with these patients is that increasing oxygen requirement and hypoxia. And that's when you're unable to deal with that with things like diuretics or fluid restriction, that's when you really have to start seriously thinking about dialysis. Of course, this is also one that's really amenable to physical exam. So you can be listening for things like crackles in the lungs, a lot of edema. Frequently, I'll ask patients if they feel like their extremities or their hands are puffy. You can look for JVP. But once again, a lot of objective data we can look at too, and it's really going to be this increasing oxygen requirement that drives a lot of my decision making. All right, and last but not least, we have uremia. Once again, kind of like electrolytes, this is pretty straightforward to think about. It's just an elevated BUN, and you measure that by checking your labs, right? And we're talking very significant elevations. Frequently, I think about it when it gets, maybe above 80 or around 100. So we're always monitoring those levels, but then you're also very much talking to your patient, seeing if they're having symptoms from this elevated BUN. And some of the most important symptoms I think about are altered mental status. Sometimes patient will complain of really persistent itching, nausea, vomiting, headache. And then another big one to think about, especially in our surgical patients, is bleeding. And remember that the bleeding of uremia is typically related to platelet dysfunction, and specifically that can be somewhat treated with DDAVP. But once again, of course, as the symptoms, they get too severe, maybe your patient's very altered, you're having uncontrollable bleeding, then you're thinking about getting the specialists involved and seeing if they agree that your patient may need dialysis. All right, so that covers the gamut, the AEIOUs of acute dialysis. Acidosis, thinking about hydrogen. Electrolytes, thinking about potassium. Ingestion, I don't really think about much. Fluid overload is, of course, just fluid. And then uremia, thinking about BUN. And then, like I said, if you remember nothing else, I want you to think about what kind of practically can I assess both in person, seeing the patient, history and physical exam, but also with objective data, primarily lab values, as well as vitals when we're thinking about hypoxia or respiratory rate. And finally, other objective data like daily weights, chest X-rays, and EKGs, and how we can put all these together and start to get a sense of when we might be pushing, towing the line, or really just acutely needing dialysis. That's it. This video is for educational purposes only. Do not use this to diagnose or treat any disease.